Just while we're kind of getting going here, I just wanted to circle back just to clarify a couple of things, because sometimes, we hear things in a way and then you think, oh, okay, well, I guess that's that. But, people are complex. So I'm just going to bug Suzanne or Amanda, you guys can flip for it, just to circle back on the notion of kind of what spirituality means and just the personal nature of it. Is it okay if I bug you guys about that?
Okay, I'll start and then she'll go.
Sounds good.
So for myself, when I'm speaking about spirituality with my clients, it is not religion, it's spirituality. For some, that is structured religion, but for others, it is not. And those practices are just something that's unique to them. And I don't actually ask to go into a lot of detail. It's just acknowledging that that's part of their personhood, and asking if they would like to discuss that or they have a need to discuss that.
You got to say what I was going to say. She stole it. No, just spirituality. It isn't religion for sure. It's practices dependent on what the person is wanting to acknowledge and what they practice. It's individualistic, and I think religion is one part, but it goes way deeper than that. There are a lot of people that I see in clinic that are not religious, or they do not identify as religious, but they do have spiritual practices. From an Indigenous lens, even if you are having a connection to the land or a connection to nature, that can be considered a spiritual practice. So I think we do have to be a little bit careful when we do try to define spirituality. Because it is so individualistic for everybody. It could mean religion for somebody, but it could also mean not religion, but I am spiritual and I connect to the land, and therefore I find my spirituality. So it is a diverse topic. It can be sensitive, for sure, to talk about religion, depending on the person and their beliefs that they have grown up with and the experiences that they have had. So I think as we go forward as clinicians, it's important just to remember to go forward with respect. Listen to your clients and what they're coming forward with. Don't have your agenda, but rather just ask them and go gently with them because it is their journey. We are supposed to be walking beside them on that journey as they go through it.
Just one more thing. Sorry, Suzanne. One more thing is just I work with First Nations, so it's kind of organic for me to have these conversations. However, for those that don't, please don't only ask those who are First Nation those questions. This is everybody. That is person-centered care, not based on culture.
Thank you. We sometimes beg for forgiveness, but there's a limit to that sometimes, and it's really, really great to have that clarification, especially when it's something new that we might not bring up necessarily in our clinic sessions, in our interactions, I should say, and just, to play with that a little bit is good. Go for it, yeah.
I'll just add to that. I know people do get afraid. As a clinician, you walk the line of being an expert in your area based on your training that you've had. But you also walk the line as a human too. So if you do come forward with that and you can display authenticity to your clients, even if you are talking about a sensitive topic, they probably will have an understanding approach if you come forward with genuine interest in trying to help your client. So just keeping that in mind, uncomfortable conversations are a part of the clinical world. Especially when someone is experiencing something such as chronic pain where there isn't a fast solution. Sometimes there isn't a solution, so we do have to be able to talk very openly with our clients and really respecting them no matter what they're coming to for culture, race, ethnicity, beliefs, values, morals. We do have to actually be able to be holistic in encompassing that as clinicians. So.
Thanks. It reminds me, I remember one of my profs 100 years ago in school talking about the notion of assuming, and had sort of a funny joke about that I won't repeat, but it's often worth thinking of, just what are my assumptions and biases as well. Nice, thanks very much. Now, keeping with our person, Amy, Now, let's say she's at that 5-year mark. So, different phase, without a doubt. A lot of experience is added on to this, one on top of the other. And we had a nice discussion about that sort of move from acute mindset more to chronic or persistent mindset. And now we're pretty much in the chronic phase, not to say that that's an all or none thing and that it's a fixed thing, it's dynamic. What should Amy be guided to do now, in your opinions and experiences, now that we're at that 5-year mark? And how does she recover from her losses? Is it too late? Is it ever too late? What things do we accept? What things do we try to change? Yeah. Anyone want to jump in first? Yeah.
I'm going to ask a question that probably may not be asked or not, but because of my background as a wound ostomy continence nurse, at the 5-year mark, I'm going to start asking the questions about continence. With a lower back injury, we know that the pelvic floor is going to become affected, and I'm going to start asking those really hard questions. Do you dribble? Do you have urgent continence? And I find, especially with women, we take that as that's part of life. That's part of aging. And it doesn't have to be. And we have amazing physiotherapists and pelvic floor physios that can help. And I think that a lot of women and men, but a lot of women really feel like this is just our lot in life. We've had babies and this is what has to happen. So with with back pain, that is one of the questions that I would start asking.
Yeah, 100%. And also remembering that everyone has a pelvic floor, as it turns out. And that's okay. Thanks. No, absolutely. And half my friends are pelvic floor physios, so I'm highly biased and collaborate often. And thankfully, that profession is expanding more to encompass all genders, all very inclusive. And there's some very educated people on sensitive conversations as well, gender-wise, so that's cool. And again, it is the back. Now, who else wants to jump in? Martha, maybe I'll ask you, because you have a lot of experience with folks who are very, very long into their experience. What do you think about things at this 5-year mark?
Well, not to reiterate the same thing too many times, but I think it's very important to help the person with pain to recognize that they are the expert on their experience. And since they've been living, she has been living with it for 5 years now, she's got a good run at figuring out, what sort of things increase it, what sort of things decrease it. But because chronic pain has the nature of flaring up, even if you're doing everything right, then and it's hard to think in the times when your pain is so high, it can be really hard to concentrate. It can be helpful to create a flare-up plan. So identifying, what are the strategies that I do to sort of maintain me on a day-to-day basis? What are some signs that I might be headed to a flare-up? And what can I do differently in that situation? And then in the case of a flare-up, what can I do? So that could include physical and psychological, nutritional, social coping strategies. And it may be a variation on a theme. So for example, if they have a daily stretching program that they do, but they notice that they're headed towards a flare-up, they might want to alter their stretches to focus on that part of the body that is flaring up. And then if they do go into flare up, then they may need to, modify the number of repetitions that they do. So having that all written down so that they can refer to it when they're going through that process and not have to sort of pull it out of their head. I think another thing that's very important is to encourage the person to focus on their accomplishments. So what they are doing, what's going right versus what they're not doing or what they're unable to do. Because it is an evolution over time, but chances are by 5 years, the person has figured some things out. And for example, instead of jogging is using the elliptical, good example. And recognizing that can really help with mood. And then I think also because we're not islands, people live in a social context. Very often there's assistance with or coaching around communication strategies that can be very helpful, so that people are able to express, yeah, I'd love to come out and meet you for a coffee, and I can stay for this long, and at that point I'll be leaving. Or I'm going to be, let's choose a seat that's sitting down low as opposed to on a bar stool, so learning how to say those things so that they're re-engaging in life. And then the last point being an OT, I'm quite interested in the person recognizing that there's more to life than being productive. Being productive is very important, but we need to ensure that in our day-to-day life that we include activities that take care of ourselves, whether that's a daily meditation practice or practicing of our spiritual activities, for example. Includes productive activities, and that's anything that seems like work. So that could be housework or volunteer work or part-time paid work, or maybe you are working full-time, but having some leisure in there as well is also very important for us to feel healthy. So I'd focus more on sort of the moving forward. This is what's going well, and how can I keep this ball rolling?
Nice. Thanks, Martha. I'm so grateful for all your experience. Penny, can I ask you for some input at this stage with your lived experience of time passing and life moving along, and the challenges with that over time that you think people would like to know, you feel we need to know about, and or things that you maybe in hindsight wish you might have known at the time?
Yeah, what came to me as, in the last bit of the conversation here is a motto that I tell particularly retirees that are having pain, but people generally, the pain patients that we deal with, are very active or driven people, or were before the pain hit. So I tell them, this is your new motto. Time you enjoy wasting is not wasted time. And that allows them the freedom, if they keep telling themselves that little mantra, that they can be free to do things that put energy and joy back into them, to relax and enjoy. And in a practical sense, and I wish I had done this better myself, I would have started, back when I first started having pain. But if you could keep some sort of a journal or calendar, or even just a list of things that you've tried, and who you tried them with, and whether they worked or they didn't, and where you went from there, because you often have a change of practitioner, and it's frustrating for them if they don't have the big picture, and it's frustrating for you to try to remember it. So I would recommend that. And then I would recommend that even if it's just a temporary replacement, I would try to find things that replace, or even if it's just a placeholder until you're better, that replace something you did before that you loved. So if it was hiking, for me, walks at the dog park with my dogs. I was saying this after we had group therapy. Some of the people that were in the group therapy continued for years to get together and walk our dogs at the dog park a couple times a week, once or twice a week. And that was a replacement for the things that I would have liked to have gone hiking in the mountains, but I can't do that. But we've got beautiful coulees here, and trails that are flat too if we need them. So even when in a wheelchair, one person in a wheelchair could come too. So there's things that you can do that replace those things. You hope they're a placeholder, but if they're not, you've got something else that brings you that satisfaction and joy and fulfillment. It makes you feel like wanting to move forward.
That was worth coming here for today. Thank you. Yeah, placeholder, I like that. I might borrow that if that's okay. Yeah, thank you. Those are wise words, and that notion of things being dynamic and not fixed as well. Yeah, really important. Some hope. Yeah. Anyone else want to jump in with thoughts around the 5-year mark? Because it changes how people need to exercise. It changes how people present. Yeah, anyone want to jump in? Jump on in, Trevor. Sorry, I'm like totally staring you down there, Rory. Yeah.
Just that statement there from Penny, so powerful, I think. And I know sitting in office looking at movement later on, moving into more later stages of chronicity, whenever that might be, again, not to define timelines, whatnot, but looking at maybe even the redefinition of what movement looks like, what the reason behind the movement is, as well as what brought us joy, what brings us joy, and how do we amalgamate those two worlds together. So exactly that. If in the past we've been really active with our walking, but now maybe the pain no longer allows us for that, how can we switch things up? What other supports might there be, which I think comes back to a motif prior of who's the best person to help support you with this in combination to yourself. So is that then aquatic therapy to then help out? Okay, that's not my area of expertise, but I know somebody just across the way who can help you with that and can help out with accessibility, right? So looking at those things, redefining and trying to figure out how do we modify this activity to your current abilities? And from those abilities, is there then a further ability to expand upon what's available, what's in the gas tank at that point? So to expand prior to the notes about energy management, that's another conversation too, is starting to redefine what this battery life looks like. So the battery being the energy and all of these different emotional, social, physical contexts then either working to recharge or to drain this battery. So maybe even redefining that movement to get an idea of what is going to help to recharge this battery at this time, to expand the battery life, that later on we can then, again, work on this redefinition process to think, all right, my battery life has expanded. I can get better usage off the top 50% of this battery. What do I want to work on that with? So that consistent kind of rolling with the punches, and I know something that stuck with me, I forget which conference I heard it at, but pain as a process rather than as a symptom. So looking at this process, both on the individual level, having, the waxing, waning, increasing, decreasing in intensity, but also learning how our body, the ability of our body moves, and then our responsibility as clinicians to ask more questions than we may give recommendations. Start to create a better understanding of what that person's experiencing, what they've experienced in the past 5 years, what the 10 years before that looked like, and how do we then pattern that back to make the best, most impactful, value-based movement program that we can now.
Thanks. Rory, I'll bug you next. I always sort of say I'll bug you and then I ask for permission. That's weird. I'm really curious about what your thoughts are, because how we might approach a physio session might look quite different at this stage as well, or not. What are your thoughts with some of the folks you work with when things have been going on for a while and it's pretty clear that it's not going to disappear in a way that we might hope?
Yeah, I kind of agree with a lot of what Trevor's saying in terms of this idea of capacity. For me, goal setting sets it up. It's, when I deal with someone who's had 5 years of pain, I ask them, I say, well, what's important to you? What do you need to be able to do? And then we develop a plan to try and work towards that or build, like he says, capacity for that. So for some people, it might be walking, and maybe Penny's walks around the lake are getting more challenging and harder. And I look at it initially from a biomechanical point of view and thinking, well, is there a reason why your walking is more challenging? Maybe your calves are really short, and maybe your calves are really weak. Maybe your back can't extend as well as it used to be able to. And when your body is stuck and there's resistance in the system, maybe if we open up some of that flow and that movement, maybe that increases your capacity. So I try and just look at what they're trying to do, and I try and think, how can I open up this body so whatever that person is trying to do is less of a burden to the body, right? We're taking the emergency brake off that car. You've been driving your car around with the emergency brake on, and I'm going to say, let's turn that thing off, and then you got a bit more flow. Another thing I consider is, building capacity. And sometimes it's this idea of patients think they need to operate at a really high intensity to get fitter, stronger, to do more. But there's other ways to build capacity. And as a perfect example, we see a lot of shoulders that have had replacement, and these shoulders no longer have the ability to generate the same force that they used to because the tendons and the stability of that shoulder is no longer the same. So what we end up doing with those kind of scenarios is we do a lot of low intensity but high volume work, right? And that trains, the deltoid and the tricep and the bicep, all the muscles surrounding the shoulder to help support the joint, and they can do more that way. So sometimes we dial back the intensity and we crank up the volume in terms of their training, and that allows these people to kind of get back to the things they like to do.
Great, thank you, awesome. Koji, I'm curious, from when we think about things like walking, I suspect that you have experience helping people with things like orthotics, walking aids, et cetera. If someone was needing some biomechanical help, because sometimes that stuff gets a bit of a bad rap right now, but it can be really helpful depending on the person, right? And as long as it's not fear-based, obviously, and you did a nice job with that. At a 5-year mark, what might be some things that you'd be curious about from an adaptability or aids perspective?
So, yeah, definitely, like in Amy's case with the chronic, basically the chronic back pain, there's different things that could be affecting that. So a lot of it is just, some re-injuries along the way where now she's kind of scared of physio and not ready to take that next step. But also just, if she does have an alignment issue, if like her biomechanics are a little bit off, if she has flat feet and there's just a lot more internal rotation that's happening with each step, then that can definitely affect her back and start increasing the compensatory movements that she needs to do now just in order to stay mobile and comfortable. So sometimes addressing those issues, so with foot orthotics and things like that, can definitely kind of give them the next a step up on progressing from where she's at. I think at a 5-year mark, with that chronic pain, and in her case specifically, it just seems to be, it hasn't really improved, and her overall situation just seems to be going downhill. I think just focusing on like a small success to kind of get, change the direction of her, the way that her life is going. If you can get her that one thing, if she can make it through a day of work without pain, or, she can do some yoga again like she was doing, pain-free, like that's a small victory for her, and she can kind of build off of that. So I think maybe with her case specifically, she just has lost confidence in the whole process because she's just kind of feeling lost. So I think even just starting with a small success, whether it's a back brace that can help, or just something that can get her out and moving more, then it gives her a good stable base to start from, and be able to have a positive outlook on, it's not the end of the world. Like there is options out there, and you just have to adjust the approach a little bit, I guess.
Great, thanks. Yeah, and it's always interesting to the biomechanic thing is always a tricky dance between danger and safety, right? This notion where sometimes people move in ways where I'm like, ooh, wow, zero pain, no problems. And figuring out with each person too, which of those things matter, which don't, and again, keeping that really individual. Hey, yeah, absolutely. Now, I'm just gonna move over to this side. I'm wondering about, at a 5-year mark, from a pharmacy perspective, is a medication, at what point do you want to go, okay, these medications might be long-term. Do we need to start looking at longer-term impacts, changing them at all? I'm curious, Jenkish, what you would be thinking with more long-term medication use requirements, and whether or not you would want to rejig that at all.
Yeah, there's always a best best idea to talk with the patient, that not just refilling their drugs, pain drugs every month. Oh yeah, I just need a. But it's that, like, always ask them that, hey, this is really helping you or not, instead of just increasing the dose every month for the same drug, or is it like a better idea to change the medication regimen that they will help them better. For example, like when Amy's case, she's keep taking opioids, right? Because if she was may have more like a nerve pain kind, if they reduce the dose of the opioids and maybe help with her like duloxetine or something like that, they maybe help with her pain too, right? And then also help with her depression, and that way at least she will feel a little bit better, and maybe she can do like more enjoy the yard work or something like that, right? So yeah, sorry.
No, that's great. And again, just the notion that things change over time. Go for it, Penny. Yeah.
I'd like to ask a question about that. If the opioids are helping, but they're not working as well as you would like, would you think at the 5-year mark it might make sense to maybe lower the dose a little bit, but make it a long-term or a slow-release type medication? So instead of those peaks and valleys of pain, there's more of a constant sense of relief. And I like the idea of from what we hear from patients that we serve, like the idea of like considering things like lyric or other nerve type pain, if that's maybe the source of the cause instead of, the opioid. But what do you think of that? I want to hear your input as a
Sorry, can you repeat the question? Sorry.
Okay, I'm saying at the 5-year mark now,
Yeah.
she's on an opioid that lasts 4 hours, let's say.
Yeah.
And so there'll be like peaks and valleys, so times where there's relief and times where there's not. Maybe would it make sense to go to something that's kind of a slow release that extends the coverage, and we can even maybe drop the dose a bit when you're adding in those nerve block,
Yeah.
nerve pain type things? What do
Yeah.
you think of that?
They're
idea?
always right now is like technology is developed so much. Like for example, such as the patches, right? They're going to release the same amount of the doses to the body, will help with the like continuous pain, and always the doctor have given a little bit of the small doses for their breakthrough pain if they need it. But always we encourage them try less as much as possible, but for the opioids one, for the breakthrough pain. But mostly they try to do the like long acting one, like they have to do like, so for example, if they do like instead of taking dilaudid of the tablet 20 a day, then if they change them to the hydromorph contain just the twice a day, and that way at least they're feeling like they're not chugging up too much pills too, always like they're on the like dependent opioids, that's taking twice a day, and then sometime it'll help a lot too, that way too.
Yeah, great, thanks. And practical stuff. Hey, yeah. Anyone over here want to have anything they want to add around this 5-year mark? Yeah, go for it, Agal.
And this comes from, I'll just blame someone else. Nancy just reminded me at the break, and it would come into the 5-year mark too, the sleep factor. She's in menopause, and again, that menopause, is 52. But I've known people 42 premenopause who are not sleeping, and I remember an experience with babies who didn't sleep and getting up in the morning, not sleeping, and having pain. And I just remember thinking, this must be what fibromyalgia is like. So then I'm thinking, like Nancy suggested, if you're not sleeping, your tissues don't have time to heal, your body's not resting. So it does come into it, that sleep, so which would also go back to a bit of HRT, a little bit of estrogen to help. I know we were very anti it, 10 years ago, but, talking a bigger picture. And we also would recognize with that estrogen, so it's not helping us sleep, we're lacking the estrogen, but also our tissues. So the healing ability of female tissues without estrogen, that's a known fact. We just don't heal as quick. If you get a tendinitis, it's worse. You get a frozen shoulder, you're menopausal. So that sleep factor that Nancy mentioned, how can we help her sleep?
100%. And I think, again, sometimes we forget there's some basic physiology that we can address. Sometimes it's physiology, not persistent pain necessarily one-to-one. I'm going to let Shannon go, and then you're going to jump in. Go for it, yeah.
Perfect. So I work with therapeutic recreation, and really our purpose in the medical world and as a profession is how can we improve someone's quality of life through recreation, leisure, or play. And really that's what you were saying as a lived experience is what are those quality of life pieces of things that you can kind of placehold as something enjoyable in your day. And at that 5-year mark, that, you know, sometimes in our field we're usually seeing them 1, 2, 3 years, but they're still in the state of extreme loss. Their world has changed. And sometimes it's about returning to what they want to do. Sometimes that might be too intense in terms of accepting that they're not able to do it in the way that they once did, and now they need to now modify that. They might not be in a place where that's acceptable, and so maybe it's about exploring new recreation and leisure that they had no idea, that maybe they enjoy painting now. Who knew I had this creative outlet? In therapeutic recreation in Lethbridge, that's where I'm based out of, but really we have services throughout all of southern Alberta, and we work with people living with chronic pain. Trevor mentioned that there's an aquatics program. We offer yoga, we offer a walking to wellness, an expressive arts, which is a creative outlet that maybe ties more into how a person's feeling, so maybe they don't want to communicate verbally, and so that opportunity to express themselves through color or mixed mediums can be another opportunity just to create space for capacity. If we aren't releasing that and we're holding all of those worries and the stress of life, you know, there's only so much of us that can go around, and we need to have those opportunities for that release. And then I just want to highlight that we as humans, we like to do what we like to do. We don't like to do what we don't like to do. And so sometimes, as much as like physiotherapy or attending medical appointments, like very valuable, but can feel mundane sometimes. And so therapeutic recreation can really bring in some spark and some like excitement into their routine and their day. And I think that's really like the value that we can provide with the approach of all of the other professionals sitting on the stage. Carrie has some posters for therapeutic recreation about what we can offer. Feel free to grab them. We work on a referral basis as well. No service fees or anything like that. So if you have questions after, please let me know.
That's great. I love that you used the word play. It's really important, actually. Yeah, and play can look lots of different ways, too, for sure. Drake, I'll go to you, and then Amanda, you're up in the queue. Go for it, Drake.
Yeah, so much with just the play aspect, just want to reinforce, like, that's something that can really de-threaten movements. Playing catch with your kid versus throwing a ball against a wall 20 times. Very different how your body's going to react and how you'll enjoy and maybe look forward to those activities. So 5 years in, coming in from like the, again, central sensitization, nociplastic pain kind of perspective, there's some, like her back pain is kind of spread. There's also like when they're talking about like a bit of numbness, some of these things can really set off our alarms where we're going, oh my gosh, now all of a sudden there's something sinister going on. So again, I have to trust you guys as doctors that we've ruled things out like cauda equina, cancer, infections, all those things. Provided that's the case, we can kind of lean into, again, what can happen is a phenomenon called smudging. There's a really good video, David Butler talks about this, where we can actually see pain spread. It goes from sharp to dull, and we can get pain, we can also get, you might find if clients have, let's say, pain in their arm, they'll notice, I'm so klutzy all the time. I'm always dropping things. I'm always hitting things over. So there's also this disconnect between the brain and the body. The homunculus is not as connected and as in tune with this. So again, that could be something with education. As the patient has these additional symptoms, they're going, something worse is going on now. This is something new, and we can gain real red flags, provided that's the case. We can give them reassurance. This is what's going on. Wrote some notes to kind of keep me on track here. So, little analogy that I'm hoping resonates with folks. When we're looking at this type of pain, it's kind of like a kid going to sleep. Most times it's, you know, the kid goes to sleep well, it's going okay, and then dad one night is like, we're going to watch a scary movie before bed, we're going to have some snacks, this is going to go great. And then, you know, that night the kid doesn't sleep so well. Rather than coming in and going like, okay, the pain, or like, just go back to sleep, If we opened the door and said that, the kid wouldn't go back to sleep. They would be laying there terrified. So what we have to do is go in and reassure, like that sound you're hearing against the window, the clock you're hearing ticking, these are normal things, not scary things. So that reassurance, reassuring they're safe, is a really big component, but it can also happen again the next night and they're getting scared, and eventually we need to kind of keep reassuring them that they're safe. So when we come to this as a physio and movement perspective, I really agree with what Rory was saying with that gradual exposure component where we're going not high intensity, not loudly bursting into the room, but we're going, what is going on here? And we're slowly increasing activity. We're slowly, showing the kid the flashlight around the body. What's actually going on here? Let's slowly explore it, reassuring that you're safe. So from a neuroscience perspective, gradual exposure, that low intensity and slowly increasing over time is the way to go. There's also, we're going to talk about biomechanics being like kind of an interesting field. I won't go down the rabbit hole, but we're just trying to repair the relationship with movement. And that can be something, it could be, it doesn't have to be targeted to the back, but it's about the person engaging those pathways in the brain, getting the body moving and building a positive relationship there. My last quick note on that is, what could get in the barrier of taking our time and moving at a slower pace is if we have this drive in us that goes, I used to be able to hike. I used to be able to do these things. And it mentioned she has a lot of guilt right now. So there could be this fear, and I think all of us have this, of like, I'm not enough, or I should be productive. It's like a perfectionist, but without the ability is a terrible place to be. So how do we get that person to love themselves and accept where they're at today? That's where mindfulness, self-compassion comes in, which Susan's group does a tremendous job with. That self-compassion, mindfulness, moving from this place, knowing that you're worth just as much as you were before, and to love yourself, that's how we can slowly move forward in that process. So focusing on function and slowly increasing over time.
Nice, thanks, Drake. There's so many great people working in pain science. We've all been lucky to be exposed to those things, and even just the language that we use. I have done a fair bit of teaching with clinicians and around language, and even one of my friends challenged me once, someone, Martha and I know, who's an OT, to record a couple sessions with permission and only for our own knowledge. How much fear language do we use? And I mean, it's like, even as someone who's super mindful of that, it's just really interesting as a little exercise of like, oh, wow, that word is a big word. Wow, look at me using that. So it's interesting, again, how powerful those things are and how you can get those alarm bells down. Amanda, I'm going to get you to jump in. You're there.
So I'm a family member. My husband has chronic back pain. And I want to bring in the family part of it, because a lot of times we only speak with the client. And depending on the client, they may or may not have the skills or have the willingness to talk about what happened in the appointment. Wherever possible, bringing in their loved ones and their support is so important. As a nurse, I would think I would have been very supportive. I was a new mom, not overly supportive. And it's helpful, especially at that 5-year mark. That's when you start to look at each other and go, this isn't changing. This is life. So how are we going to do this? We need to modify our home. We need OT to come in. Now I can't have the shelf anymore because my husband needs the shelf. I need to work out of the drawers in my bathroom. Like, things change. Everything becomes, now I have to work around how can my husband work and get things through. So it's really important to bring in that family so that hopefully the spouses can start having conversations as to how they can support each other, because even though he's the one with the injury, I mean, sometimes you just kind of get angry, and I'm the one dealing with it. I'm the one that has to do all this. And the other part of it that can become affected that we don't talk about, because again, it's uncomfortable, is their sexual relationships. And so how is that affecting their relationship?
You read my mind. I was just thinking about a conversation I had recently around positioning and how to make that comfortable and bring joy and playfulness, whatever it is. And sometimes, you have to work your way into that, obviously, with someone. It's not always a go-to zone, but that's part of being a human being as well. And it has a big impact without a doubt. Yeah. And there's always a way. It's just figuring out what that is. Susan or Tracy, I'm just wondering if you have anything to chime in with around this sort of 5-year mark from either of your perspectives.
Yeah, I can chime in. So as someone who would see a client coming in at the 5-year mark as a clinician, we get to kind of be the person that is the contact. So we've referred, the person has tried stuff, then they're coming back to the office, and really we get to actually be the one to be able to put that all together. When I first started practice, I got really interested in trying to figure out and solve the problem and move forward, that I actually had to always remember to don't forget to circle back, reassess, and go from there. Because at the 5-year mark, I think, Drake, you touched on a little bit, we still have to keep thinking, is something progressing in their case scenario where you do have to rule out something ominous, right? We can't forget that in the back of our minds as clinicians as we delve forward. Also at the 5-year mark, we should have a pretty good relationship with that client at that time and know what really is working for them, what's not working for them, from a biological perspective, from a psychological perspective, and then from a social perspective as well. So we actually get the position as a clinician to be able to help continue on that journey with that person. So it's actually a really interesting position to be in at a chronic pain kind of long-term mark. But I think just really importantly remembering not to forget to circle back, to forget to really monitor if things are changing within that chronic time frame that you're dealing with, and not to forget about anything that could also be secondary in causing concerns.
Great, thanks. And then from sort of social work therapist or dietary perspective, any thoughts from you two down at the end of the row there?
Okay. Well, thank you. There's been a couple plugs for group therapy, which is awesome. And hopefully at this 5-year mark, if it's been identified that there's more life stressors, maybe anxiety or depression, then they've made their way to our group. Because I think the pain education that Drake's program offers, and then just we can expand with cognitive behavior therapy. The mindfulness-based cognitive behavior therapy is really great. Mindful self-compassion we also offer. And then for some people, dialectic behavior therapy is really helpful for distress tolerance, interpersonal effectiveness. So yeah, it kind of goes beyond the self-management skills from the chronic pain group. If people are needing, there's a whole bunch of other therapy groups that we do offer. And under the addiction mental health umbrella, there would be access to like addiction counselors. We also have our own team of recreation therapists and individual therapists. So there's different types of groups. When mental health is identified or addictions is identified, then they can, now we have similar art, yoga, swimming, just movement kind of based things. There's a little bit about the safety in me stuff that Drake was bringing up. I know it goes into the next thing, but I was encouraged to talk about this. In our therapy groups, there's opportunity. It's not just educational, it's process-based. So people might start sharing things, and we can ask them, like, where do you experience that in your body, right? We can get to those fear thoughts. We can get to, like, is that a danger signal that might be happening here? And then what happens to your body? What happens to the action, like your behavior, and so on. So we get time with people to hear them out and then help them process how to bring more safety into their thoughts and into their body. So through practices, mindfulness, bringing down, like a lot of the mindful practices that even in DBT are around the nervous system and regulating the body. So it really does fit in here too. And I guess that's it.
And I guess for me, from a nutrition perspective, it would be similar to when we had met before, like, again, asking them, where are you at? Maybe last time it was about the meal prep and the meal planning, and this time they're like, hey, what about my diet quality? Like, what am I missing? Is there something I'm missing? Is there something I can be having, right? So, I mean, maybe at that point, we're talking about fiber and gut health and talking about prebiotics, probiotics, and looking at specific minerals like magnesium, vitamin D, vitamin B12, if that's where they're at, right? In the mention of supplements, of course, I always get asked that question too about supplements, and I send them to you most of the time, just to make sure they're not interfering with medications, right? And also, we have that conversation, and if they're in my office, like, we'll just even look online together and see what it's all about, right? And look for red flags, like, is somebody making a lot of money from this, right? And if it sounds too good to be true, it probably is. Having that talk with them, right? And also just talking about, when we talk about single nutrients from, a supplement, we're missing out from the whole food experience, right? So if I take vitamin C as a supplement, well, what about the orange, right? Because from the orange, I'm getting the vitamin C, but I'm also getting the fiber and all the other good stuff with it too, right? So, yeah.
Awesome, that's fantastic. I think one kind of final little thing before we move into questions from all you lovely humans out there who have been taking all this in. One of our sort of, speaking of goals, right? One of our goals for having this session today was to bring people together. Again, I'm a small town person, so I always call a friend and say, what do you think? Or we meet. There's some nice energy around that. After today and sort of moving forward, I'm curious about how each and all of you feel about how might you collaborate in terms of working with each other, which some of you do already, when you're often in different locations. Because I know that's challenging. I work in private practice, and I know I got to call people, and that's fine. It takes time. But I'm just curious about your thoughts, whether you have tips and tricks, things that have worked well to share with the audience around how to collaborate in productive, efficient ways without, really not feeling good. So I'll just throw it out there, jump in, whoever has thoughts on that.
Trevor and I were talking earlier that Connect Care through Alberta Health Services has really made a big difference. I'm seeing that my patients are attending in service. He's seeing what I'm doing in my treatments as well, and he's able to actually see the exercise that I'm prescribing, and he can integrate that into his work as well. So for me, Connect Care has been a massive jump forward. Even just seeing how his last name is spelled, right? So I'm just kind of like, okay, that's the Trevor that they're talking about in that dark abyss of Melcor Tower
It's
downtown.
the simple things, right?
But then you get to kind of know, and then you connect, or like, that's the human.
Yeah.
Okay, I trust this guy, he seems reasonable. So when the patient comes back with an odd story, sometimes you're like, I'm pretty sure Trevor wouldn't do that. So
Or you'll
let's
call
ask
him
some more
out.
questions regarding this. So it just helps clear the air. So I guess technology has been helpful.
That's great, and it's funny because those technologies often get bad press, right? Anyone else want to jump in with productive ways to collaborate and communicate? Yeah, go for it.
I know I'm very tempted to jump to, the practical pieces, which are super important. And technology, I'll agree, like, we're all pretty friendly folks up here. You can just email us anytime. But I think also recognizing internally what can get in the way, and I'll speak for myself, my first year into this type of work was, we talk about guidelines and how messy they are, and I was going like, oh my gosh, everyone else knows how to manage chronic pain, and I have no idea what I'm doing. But as we've discussed today, it's super complex, that it's not a linear process. So many team members have to be involved. So I think looking at looking inward is to go like, know that you can ask questions and you don't have to have it all figured out. As healthcare professionals, we want the best for our patients, and knowing when we don't have the answer and feeling comfortable to ask our colleagues, I think is a really, really big skill, and to get over that pride and recognize, we're all here to learn more about pain. Otherwise, you wouldn't show up today. So having that trust that you can ask and building those connections as well.
Totally, thanks. And Martha, I'll just ask you if you have thoughts on that, because I know you've worked under big roofs with lots of people and then on your own in a solo practice. Do you have thoughts around collaborating on helping folks?
Yeah, so now in my private practice, I frequently will call up other practitioners on the team with the client's permission, of course, to coordinate our care to ensure that we're giving similar messages. I also often suggest that we have a team meeting with the client. If they're dealing with a particular issue that we're trying to both help them with, or maybe there's more than two of us who are trying to help them with it, so that the three of us can put our heads together, or if they're at a milestone, like they're about to return to work, and they've got qualms or questions about that, so that everybody's on the same page. Yeah, I liked working under the same roof as other clinicians a lot better, because it's quicker and you can have informal conversations, just quickly pull aside into a private space to chat, as well as the formal meetings. But this works okay in private practice, and including the client, I think is important.
Awesome, thanks. I often find too, even when we send doctors letters, because it's important that everyone knows what's going on, and having the capacity for patients to look at that letter that's getting sent as well, when it's, just to share that as well. Anyone over here have thoughts around working together? Yeah, go for it, jump on in.
So chronic pain is like one aspect of a complex medical system. There's so many nuances in diagnosis, and I know we all live that. So how are we like a master of all, but really understanding and recognizing that there's a lot of diverse people that we're working with? I think that part of sharing and communicating, our panel today and all of you guys in the room is part of advancing and like recognizing what options are out there. There's a resource called the Canadian Pain Task Force that addresses what is like Canada's approach to managing and moving through chronic pain. And part of it is going to conferences and presenting and sharing what are you doing so that others can begin to learn. Like this is just one component of our clients' experience or diagnoses. The other thing that I wanted to add to is therapeutic recreation is part of the Alberta Healthy Living Program's Explain Pain program. And through that collaboration, and Drake, you can speak further into it, but the exposure of bringing in multiple disciplines to present in the, is it 8 weeks or 12-week series? 8. It can help to kind of help those patients or the participants in the group decide, is this something I want to explore further? They have people talking about dietary, or if it is therapeutic recreation, do they want to explore that, or is that not of interest right now? Maybe you can speak further, Drake.
Just on kind of like the exposure to different things? Yeah, that's something that I think, the clients get to witness within the program. They get to hear from all the different disciplines, both within that class, and then ask questions or set up like one-to-one appointments afterwards. So like for a truly biopsychosocial approach, you need those different team members to be in there. And it's also something, there's some secondary wins that have happened already when it's like, what did you learn in last class? And then like we're kind of hearing from other clinicians, and we're like, oh, keep that in the toolbox. And now we're starting to set up some more like formal meetings where we're doing actually exchange of education from each other on like what are the main topics that we talk about, because you can have a chronic pain patient come in to, let's say, a rec appointment or let's say a nutrition appointment, and what might be on their mind might actually be something they learned from movement, and we might actually have some basic information we can make sure we're at least aligning in messaging. Because when you have one person saying your body is broken and the other person is like talking about the nervous system, how does that feel as a patient? You don't have confidence to move. So making sure we're aligning, having those connections is really important.
That's great. One of my friends calls that poaching from the best with pride. Now, maybe Penny, I'd love to hear what you have to say about collaborating with, as you being the anchor person of your team, and if you have any thoughts around how people can maybe do that better, things that you found helpful in terms of getting your team to communicate well with each other.
Okay, you mean my medical team that treats me? I haven't had a terrible haven't had a lot of luck with it because everybody is stretched so very thin. So people have the time to give you that they have available when you have your appointment usually, or your session or whatever. So I feel like the patient, in a way, often has to be their own anchor person and also communicate to the doctor what they're learning from their physiotherapist or their occupational therapist. I have had good care, don't get me wrong, I've had outstanding care. And like when I wasn't able to take care of myself, an occupational therapist came to my house and nurses and helped me set up my house so I could get in and out of bed and things like that. I've had great care and great group therapy and great, lots of great services. I'm a great pain doctor, garden, so on. But it's just, I think in this situation that we find ourselves right now, patients have to do a lot of the collaboration right now, unless there's some other system that I'm unaware of. I don't know. Yeah, that's the way it is, isn't it, Tracy?
Okay, yeah, and that's a good reality check. And also motivating, I think, for all of us too, about, okay, where are those little pieces that we can do just a little bit more? Yeah, go for it.
I think it's just kind of a testament to what that Alberta Healthy Living program is built, though, right? Like what she's describing is like, I don't have a collaborative team, and they've built some structure here, with exercise and pain education and dietary concerns and mental health supports, right? And I think, to me, we all recognize we can't solve this on our own as a practitioner. We have to have a team approach. And I think the structure of that approach needs to be built that way, where we are interconnected, where we have lunch together, where we have these open discussions, because doing this every 5 years is helpful, but on a daily basis, there needs to be structure.
Yeah, I know, and that's good. And I find in my private practice too, I have a lot of teams, but everyone's in different spaces. And it's an email here, it's a phone call there. But it's possible. It doesn't have to be super labor intensive. It is possible, and it makes everyone's life so much easier if we all know what's going on. Quick, okay, because we got to get into Q&A. Go for it. Yeah.
I'll be very quick, because I think that's something. Yeah, it's not perfect, and that's the stuff we want to hear, is like calling out, like, to be unprofessional, but which parts suck. Like, this part sucks. I've had to tell my story 5 times to the same team member on your team. That shouldn't happen, because we have to redo an intake, which again we book a lot of time for. That patient has to go through their story of the most painful events in their life. That should not be happening. So that's something like, yeah, we're very much working on that stuff, like as a team. Like, if we do that intake, I can pass that to the next team member and go, this is what's going on. You don't have to ask these same things again. So it's that continuing refining, and that feedback is what we need to make things better. So appreciate it.
Yeah, and just not re-traumatizing. Yeah, absolutely. Now, in our remaining time, these lovely humans up here and the brains attached to their bodies are available. They're here to answer questions. So we have a mic there, and I think, where's Phil Donahue? Phil, do you have a mic? Phyllis Donahue. Sylvia's got a mic that she can pass around as well. And please come and ask questions of us. This is a captive crew here, and we are here to answer your questions. So don't be shy. Otherwise, we'll have to ask you questions. Oh, can you get it? Okay, awesome. Go for it, Martin.
Hello. So my name is Martin, working as a social worker for Alberta Health Services around the mental health therapy. So could you elaborate on the significance of guiding patients towards shifting the alarm system when they're dealing with chronic pain, from going from the sympathetic nervous system to the parasympathetic nervous system, which in order to alleviate the chronic pain? And also additionally, do you have any insight into whether PEMF, so pulse electromagnetic field, can help the patient to shift that alarm system, focusing on the macrovascularization I'm reading more and more research now that this is a field that can help in mental health, but also on the medical side. Thank you.
Yeah, those are great questions. Who wants to tackle? No, Susan, go for it. Because yeah, anyone, jump on in.
I'll give a swing at it, and we'll go from there. Because yeah, the parasympathetic, sympathetic. I try to keep it like simple language of just going like, we're trying to help the person feel safe. So it could be like directly addressing those fears of like, I'm not enough, and helping them recognize that. Or it could be things going on in their life, external stressors that could be at work or loss of function, could be relationships. So DIMS and SIMS, if that's something we want to learn more about, talk to me another time. But that'd be what we're trying to address is holistically, how do we help the nervous system calm down? When it came to like the electromagnetic, I obviously don't know anything on this, but there's a lot of things that come up as like, I think it was spinal stimulators was another one that they're like, this is really, really great, and it can be helpful for a lot of people, but we also got to think like clinically in practice, like, is this going to be practical, and how accessible is this going to be before like where we want to put our focus? Like, if it better have a dang good treatment, like it better be, 100% extremely effective, thank you, if it's, if we're gonna put a lot of focus and energy on it, because we're gonna be really limited on how many people can get there. So that's something, yeah, whenever we look at kind of these other things that come up, I always keep a little bit of skepticism, because clinically, how accessible are they as well? So I don't know enough on it, but that's kind of my take on those things that come out too.
Yeah, go for it. Yeah.
I'd add just a quick thing in session, and I think even if you're not a mental health therapist, but having, like practicing the breathing techniques, because somebody said earlier, like, physio, that didn't work for me. Kind of same with breathing techniques or meditation or mindfulness. People think, that doesn't work for me. So practice different types with people, and just see what does work for them. Yeah. Do lots of that, and right in session, not just tell somebody about it, you should try this, or here's your homework for the week, but actually do it with them and ask them after how it was. Yeah,
That's a great way to do it. And how can we give that nervous system a hug in a safe way? Yeah, absolutely. And I really like what you said, Susan, about doing those things supportively, because half of it is building confidence and coaching, and we feel better too. That's the, that's the hack.
Yeah, so that people don't think they're doing it wrong, or right, that they're not good enough at it or something, because that's not it at all.
Yeah, absolutely. Yeah. Any other questions? You have these smart people here. It's great. No pressure.
Hi, my name's Samantha. I'm a physiotherapist in private practice. I was just wondering, so I think it's great about the multidisciplinary team that you've been getting. This is kind of the first time I've heard of this, that you have access to this in Lethbridge. Same with my colleagues, we hadn't heard of that before. I was wondering whether there was any way that you guys were going to kind of put that out there to other healthcare providers about kind of knowing that there is that pathway there, even with like managing chronic pain patients, talk to doctors and things like that a lot. I haven't ever heard of that through them either, so I was wondering whether you were implementing any guidance or anything for access to that in Lethbridge.
Okay. All right. Not talking too much. So, that's something when we've talked about marketing or health awareness or health promotion. Without getting like too political, the climate right now, not a lot of budget dedicated to that stuff. So you're looking at the marketing kind of lead for our program right now. So to talk about like practical what's been on the ground is we've done some tearaway posters, which have gone up in all the clinics, and I've actually seen them get torn away, which I'm hoping was good for those little numbers at the bottom. And then we need more. So there's been, that was one initiative, and then we did do a lot of kind of lunch and learns within clinics that have been interested. So a lot of the focus has been on the PCN in the area, but yes, as far as private physio, or even private services, it's been kind of like ad hoc when we have capacity, which is a little tough at times. So that's something that is a huge need, is getting that awareness out there so that we can like fully utilize this as well too.
Thanks, Trey. I think the thing about days like today too is getting to know people too, right? Our community, I think those of us who work in private practice, we know you need an army around you in town, and not just in town, elsewhere. And who are those people you can call, take courses, go to conferences, chat with each other, geek out in those 30 seconds between patients, and, you know, call people too. I always think everyone, we're very kind people in sharing our knowledge. Hey, yeah, go for it, Penny, yeah.
A resource you might not think of is your MLA. They get calls from everybody in the general public about all kinds of healthcare issues. And they have connections that none of the rest of us have right into the health minister. And so if you share with your MLA that you are having, that you know this is out there and you can't get access to it, or you feel like there needs to be a better organization, putting pressure, or at least putting information into that location, can really have good results. We've seen some very good results going that route with our patients that we serve. So I think that it could work for clinicians as well.
Yeah, my name's Jennifer. I'm the pharmacist with PARP and Seniors Day programs. Just to kind of add to the comment about how to access or find out about Alberta Healthy Living chronic pain program, I've tried to refer a number of clients to your program, and usually I go to the website and try to print off information, but it doesn't print very nicely. So I've always looked for a brochure from you guys, because a lot of my patients are very resistive. I mean, they usually come to me because they are looking for drug therapy, and sometimes they don't really want to look beyond that for treatment. So it'd be nice to have a brochure that we could even just print online. It hopefully wouldn't cost too much to create, but that we can just that explains your program, maybe some of the benefits to them, to help us as clinicians convince people to go to your program, because I find that's really a barrier for me, is that a lot of people are really resistive of going to the program for whatever reason.
Okay, so some technology there a little bit. Fair. The other thing too, there's all these resources that sometimes you think everyone knows about. Like I think everyone knows that there's a Find a Physio search engine in Alberta, but not everyone knows that. And it can, things like that can help you find people who have experience and expertise in chronic pain too, so you're not chasing all over town. And I know the OTs have that as well too. Yeah, I think the mic, where did the mic go? Oh, go for it, yes.
Hi, my name is Tracy with Help Alberta's Pain, and I have a question for our mental health. But before I do, Penny mentioned that patients have to do a lot of the work themselves to act as the center of their team and get that team support and stuff like that. The same is true for what you were saying about not being able to find resources. Every community that we work in all across Alberta, we have trouble finding resources, and are surprised when something pops up. But what we noticed is that the communities that have the tightest connection between supportive services has the best knowledge of what's available in their communities. So that means the physiotherapist mentioned to the kinesiologist, who mentioned to the dietitian, who mentioned to a patient, who mentioned to their family doctor, and it spreads. It spreads. So as professionals, we need to make sure that that information moves amongst ourselves and amongst our patients, and patients are a powerful way of getting that information across. But my question to you is about the 5-year mark. So yeah, we've reached that point where all of a sudden everything has to change, where we realize that it's not going to go away. It's like the period at the end of the sentence. But it's also that point where for a lot of patients it's important that maybe what we consider a victory changes too. That maybe it's not that we're going to suddenly be pain-free or find the cure, but maybe we're going to find a different way of living our lives with a different outlook and different quality. How does mental health, what is mental health's ability to help in that? Because usually we find patients aren't referred for that, they're referred when they get so depressed that they can't stand up in the morning.
Right, right. I think you're talking about acceptance in a lot of ways, right? Like kind of that radical acceptance of, and it takes people time to get to that, because acceptance just isn't like, okay, I accept this and now I can move on. It's like a daily sort of, it ebbs and flows for sure. So I think in mental health, definitely in group therapy, we might see people at different levels of, or different stages of that, right? So when you can see people in the group that have maybe come to a place where they can find meaning in other things, they've adapted the way that they live to have activities that now they enjoy, it just gives others a bit of hope. Maybe some motivation to also feel like they could do that. So we talk a lot about acceptance, but it's something that some people aren't just ready for yet, right? Even 5 years in, I don't think a time is on it. It's more just that, but I think being with other people, the attitudes can shift, right? The way you think about things can shift. And you have a whole bunch of people supporting you and encouraging you in a validating way, right? So.
Any, there's a question over Flo, yeah. Yeah, for sure. Oh, sorry.
I can just speak loudly.
Go for it. Yeah, let it rip.
I just noticed that Martha has put a number of resources in the chat. Would you be able to email those to us after?
Yeah, what our hope is that everyone on the panel that has mentioned resources today, and I'll ask this of you, Martha, if you could email those to Sylvia, and then we can fan that out. I will do that even, Sylvia. We, Sylvia / me, will get those off, because the whole goal today is to have those resources available. Otherwise, we'll never remember them. So yes. So Martha, if you could please email those to us, that would be great, and we can pass them on. Yeah, in the back, there's a question from Flo. Go for it.
Hi, my name's Flo. I'm a pain management consultant in private practice. I have a question for the team. One of the most important things is to teach people how to auto-regulate, right? And pain creates fear. And sometimes we as clinicians are, pressed for time. One of the key aspects in preparing for being with a patient is, are you yourself as a clinician auto-regulated? I would like to hear what the team has to say about that. That's on stage. And then the second part is, that's great that we have Connect Care, but sometimes people move from AHS services to the private sector. And then the re-traumatization occurs because all that information is lost. How can we transform that process so it's less traumatizing to the client, to the person with pain?
Why don't we start with the auto-regulation? What's your favorite auto-regulation? We all have one. Anyone?
I think as a practitioner, if I don't have energy, it's very hard to give energy out. And, I've worked with acupuncture, and in that sector, I really noticed I have to be careful of my energy. So you do learn that to be a good practitioner, I've got to have good energy. So things I do, I think that's something we all, we work at constantly, but things like yoga, meditation, doing what I love, getting out to hike, outdoors for me, spending time with people, that regenerates my battery, because we talked about the batteries being low, and we can burn out, especially dealing with chronic pain clients. We all know that feeling, so we have to really work on not burning out. And even going to presentations like this and learning more, that's going to help us as practitioners. So that would be my personal view. Anyone
Can I just
else?
do a follow-up on that?
We've just got 5 minutes, so Flo, just hang on. Okay, I'm just going to get the panel to answer the question first, okay? Just in the interest of time. Shannon, go for it. Then you have the mic. Go for it. You're fine.
What came up for me, like I love the question, and in some ways it felt challenging. And I wanted to say, like, oh yes, I am present. I am right there with that client. I'm holding space for them. In reality, there's times when I'm not. I am human. I have kind of this mindset of, I want to be mindful. I want to catch myself in those moments and say, I'm skipping ahead to the next question. I'm already thinking about my response. So I know we talked a little bit about, I think Drake, you mentioned something about being like introspective. And just like our clients or the people we're working with, that takes work, and it doesn't happen overnight in terms of that change. So as much as I want to say I'm present and I do my best, I'm human.
Why don't we take one last thought? I'll maybe give it to Martha, because I feel like you've been so patient up there on the big screen all day. What are your thoughts around what you do to self-regulate around being a good clinician?
Well, I agree with everything that's been said so far, and I do try to practice that because I preach that. So honestly, one of the reasons I went into private practice is that I could have control over my schedule. So I build walking breaks into my day. I also have little tools with me at my desk, things that I can ground myself with by feeling with my fingers if I notice that I'm being reactive to something that a client is saying, to ground myself so that I could be present with them. I don't think there's anything sort of magic about it. It's those strategies that have already been mentioned, and so some of them are physical in nature, to give yourself your body a break from being at a desk if you're doing virtual stuff, and part of it is mental health, just taking a break from all the thinking and focusing on the present.
Nice. I think, do we have one more question? Yeah, I'll go for it. Yeah, we'll finish off with your question if that's
no worries.
okay.
I'm going to stand up. I can't do this sitting down. Okay. Hey, Drake. I used to work with Drake. My name is Jen. I'm a mental health therapist, nursing background for outreach. So when I hear kind of pain and chronic pain and stuff, for me, I work with the end stage. Now they have a pattern of dependence with something. And my question is, with this lovely panel that we have here, in addiction, recovery comes, I usually like to think of it, recovery comes from many places. And with pain management, that seems similar to what addiction would be, right? So I'm thinking, how do we keep people from going into the pattern of dependence? And then once they're very far down the road and now they're maybe living rough or shelter living, and they want to get out, then how do we pull them out of that? Is my big contextual question.
Suzanne, do you want to tackle that?
Sure.
Yeah.
So for those of you who don't know, I'm the director of the homeless shelter here, so I might be able to help. That is a very complicated situation for people to find themselves. And it goes all the way back when you start talking about substance use and addictions to where it kind of started. And that can go all the way back to where people are coming from. So varying levels of trauma and what led them to actually getting into their addictive substance, whether it be opioids or alcohol or other substances as well. So once they do get there, a lot of people often wonder, was that a moral choice that they chose to try that route? And I think it's important to actually address that it's not a moral choice. It becomes an addiction and a need. And once that's crossed, then it becomes really hard for that person just to decide, hey, I'm going to stop this and go back to life. And that's where we see all the complicated fallout from that. So, maybe you lose your job, maybe you alienate your family and you lose your home and you do end up unsheltered. And then, the problems are compounding and compounding. it does get extremely hard for people to, by themselves, just reverse all of the issues that are coming at them and the inequities in health and the barriers. It takes a lot of different multifaceted professionals to help each individual that is going through. So it's, you could see, in a nutshell, this is like a whole conference unto itself, but in a nutshell, how complex it gets, and very, very quickly. All the while, you're trying to prevent people from, overdosing, and that 911 urgent, we're preventing death. So the crisis is always there for people. It's always there for the people that are helping as well. So just finding that balance to try to meet that person where they would like to be met. I find that the one thing that people really value that have maybe lost everything else is their autonomy, their dignity. And sometimes that means they will say no because they can. Yep, and we have to be respectful of that, and we have to be able to be willing to meet them at their level and say, okay, how would you like to move forward? How can I help you? Because at the end of the day, it's not about Suzanne as the clinician, it is about the person that is having the experience. So I think that that is important to remember. That's the first step to being able to build that connection and start unwinding that very complicated journey that they're on. But don't ever leave them by themselves on that journey. So I hope that answered it in a nutshell.
I kind of was wondering too, like with the pain clinic and stuff, like are there services for these individuals that are in severe dependence? And that we say, hey Drake, I have someone for you. Like, are there services intact to be able to help with this part of pain management as they come out of their dependence?
Yeah, so great question. Obviously, we work together. My background prior to this was addictions, both within HS and within nonprofit in the community. Quick background was, I used to do street nursing, and we talked about burnout before and witnessed more than, a lot of people unfortunately died, and I took time off for that. So that's something, when we talk about burnout, something I'm always kind of self-aware on. Where am I at? Coming into this field, that was something that made a lot of these things from addictions kind of click. When we're talking about emotional injuries matter, who would have thunk? But that's something that we now see. And Susan just talked about that importance of connection, where if I say the words Rat Park, or the study Rat Park, who knows what I'm talking about? We got Jen, we got this side, mental health crew. Okay, Rat Park is a study by Simon Alexander, and I believe in the 80s, where we talked about, like, the war on drugs was really huge. We talked about substance being a hook into people's brains, and that's what's killing people. But Simon Alexander, a Canadian, recognized, people don't live isolation. We don't put rats or people in these cages by themselves. So what he did was a study where we did rats by themselves with just a substance. And obviously, we know the results. They died and got addicted to those substances. But he also put a control group or an experimental group where we put rats in a rat park where they had friends and family and wheels to run around. They had space. There was light. It was a beautiful area. Exact opposite relationship happened. So this is extremely important to know when we talk about the importance of connection, where people need to feel loved. They need to love who they are and have someone with them in that journey of, maybe they have guilt or shame of things that weren't in their control from their childhood and stuff. But that importance of connection, there's a really clinical component there too that's so important. Coming to the question about, like, the pain group and what we offer here too, that's something that, again, when we started this program, it was January 2020 where I walked in and there was a desk and it said, here you go. That was when COVID happened. I'm not sure if people know what COVID was, but that was when we started. So again, through that time, I think we've built up a program that's okay and meets a couple groups' needs, but there are some huge, tremendous gaps in our program and in the community as a whole, where our group is currently, some of our classes we do online, some of them we do one-to-ones in person. There's some gaps with rural and Indigenous communities that we need to mend, as well as with youth in chronic pain, just as prevalent. 1 in 5 people in the world have chronic pain, and it's the same numbers for youth. we do not have supports for youth, and that needs to happen. When we have English as a second language, there's another group that we need to meet as well. So there's some really big gaps that we have identified, and we're trying to build those. For clients with opioid use, that's something we do have to kind of assess, like, are they in a place of readiness? Is education going to be effective for them? As well as we've tried to, take this 8-week group, how can we do this in one-to-one visits and really target that education? And coming to the note of opioid use, and we talked about this earlier, our philosophy is the most amount of pain relief with the least amount of medication. So if they're still on opioids at the end of the day, but they're getting a lot of pain relief, they're returning to their life, function, quality is improving, and they're still on opioids, awesome. As long as there's no red flags and it's been stable, which we have a lot of cases where patients have been stable for many years or decades and then they get taken off where there was no concerns. So when it comes to that opioid use, there's a metaphor that I got. I forget the source, but it was basically like, if we have our hand on our cliff and opioids is the one finger that's keeping me on with my pain relief, we need to get other skills intact that we can really hold on to this cliff. And then if the patient wants to, they can let go of that piece if they want to. But I don't think we stand a chance unless we have those other things and connections and skills in place. So I agree with you, huge need, and we're working on improving that. And I'm hoping that we get there. Thanks, Jen.
Great.
Can I just add something?
Oops, I'm sorry.
Can I add something?
Oh, go for it, Martha. Sorry, I was like, where's that voice coming from? That's super funny.
Just briefly, I think it's important to recognize that medications aren't the only thing that people can become dependent on. There's other passive treatments that people can become dependent on because they offer temporary relief, whether it's some sort of manipulation of their body, or whether it's a massage, or sort of downloading their grievances to their counselor, that have temporary relief, but it's not an ongoing help for them in improving their functioning. And so I think, and this is not an original thought, that we need to introduce the concepts of self-management and management of anxiety and depression, to offer people tools early on in their journey. And I mean, there's been a big push in primary care networks as far as, promoting healthy lifestyles, and that's part of it. But I think that there's more work to be done, and the Chronic Pain Center in Calgary has been doing some outreach education to PCNs, not just in the Calgary area, but across the central and southern part of the province, to educate the family physicians on how to promote this way of thinking that this is your role, and that behavioral health consultants have been brought into primary care networks to facilitate that as well, so that people feel empowered to do something about whatever their chronic illness is, including chronic pain.
Thanks, Martha. I think we'll end on that, really, with those wise words. And before everyone goes, just another plug, please, for the evaluations. We really appreciate feedback. As I said, the good, the bad, and the ugly. And there's a basket by the door for those. And I'd just like to take this opportunity to thank everyone who came today, all of you. Such a great way to spend time and learn from each other. And what a really awesome panel. Wow. I'd like to give you guys a big hand. Good job.